Okay, so the idea is to talk about pneumonectomy, meaning taking out one of the lungs, totally taking out one of the lungs. So mainly on the radiographical features we will talk about, and then we will talk about lobectomy and subsegmental or segmental resection as part of pneumonectomy, even though pneumonectomy, when we're saying pneumonectomy, is taking out all of the lung, all of one side of the lungs, not all the lungs, just one side. Then we will talk about the post-pneumonectomy syndrome, and with that we will finish off. So let's start with pneumonectomy. When we're looking at pneumonectomy, usually in 4 to 7 days after pneumonectomy, after taking off one of the lungs, 2/3 of the hemithorax will filled with fluids. So we want to film it again and again, and to see this gradual fill in, and that the air bubbles is not getting bigger, because if there are air bubbles that are increasing in size, it may suggest that there is bronchopleural fistula that develop after the pneumonectomy. So we want to see this gradual fill without the bubble getting bigger. Think about bronchopleural fistula when you're looking at these patients. Now, what we will also see is that gradually the mediastinum will shift to the side of the pneumonectomy side, the side without the lung. And it includes the lung in the other side, in the contralateral side. The contralateral lung can herniate to the side of the pneumonectomy. And it may look as though that the lung, there is residual lung in the pneumonectomy side. It's not that there is residual lung, it's just that the lung from the other side just herniated to the side that the lung was taken off. Now, when we are talking about lobectomy, not pneumonectomy, only lobectomy, taking off only one lobe of the lung, the remaining lobes will usually expand in order to fill the void that was created by the lobectomy. A little bit you will see shifting of the mediastinum, and the diaphragm on the same side will go up a little bit and will be elevated because of this void that was created. Now let's go even smaller and talk about the subsegmental or segmental resection. Now, because it's smaller, we almost won't see any rearrangement of the parenchyma. Now, we can see postoperative opacities that are quite common, and those are the main things that can be seen in segmental resections. Almost no rearrangement of the parenchyma because it's small, but there will be opacities. So we talked about pneumonectomy, lobectomy, and subsegmental resection. Let's talk about post-pneumonectomy syndrome, which is quite rare. And it talks about the area obstruction that may occur after a pulmonary resection. It occurs due to the shift of the mediastinum and maybe the rotation of the hilar structure. It most often occurs when there is right pneumonectomy or left pneumonectomy when there is a right arch that is present. Now, bottom line, post-pneumonectomy syndrome is airway obstruction because of the resection, because the shift of mediastinum will become rotation of the hilar structure. Now, the radiographical features of this post-pneumonectomy syndrome is airway obstruction, because this is the complication. This is the post-pneumonectomy syndrome, airway obstruction. So you will see hyperinflated lung because the air is stuck. There is air trapping. And there is destruction of the bronchi, bronchiectasis, and recurrent pneumonia because there is stasis. You can see narrowing of the bronchi and trachea. The contralateral lung may hyperinflate, and there will be marked shift of mediastinum. Okay, so post-pneumonectomy syndrome is mainly about airway obstruction because the void that was created, which caused the mediastinum to shift or the hilar structure to rotate. But in the end of the day, post-pneumonectomy syndrome is airway obstruction, and the radiographical features is according to air obstruction, air trapping. So this is it. This was about pneumonectomy, lobectomy, segmental resection or subsegmental resection, on the radiographical features of it, and a little bit about the post-pneumonectomy syndrome, which is mainly about airway obstruction. Thank you very much. If there are any mistakes or a correction, maybe let's talk about another thing. Remember that when we talked about pneumonectomy, we talked about an air bubble that we need to look for if it's getting bigger, because if it gets bigger with time, we need to suspect bronchopleural fistula, what is shortly abbreviated as BPF, bronchopleural fistula. And if there is bronchopleural fistula, the air bubble will get bigger and bigger. So what is it, bronchopleural fistula? As the name suggests, it's a fistula between the bronchus and the pleural space. Now, around 2 to 4% of pneumonectomy patients develop this bronchopleural fistula. Now, when we have large fistula, remember that we said that in the pneumonectomy side there will be 2/3 of the chest that will be let's say filled with fluid. So if the bronchopleural fistula is big, fluid will get from this area to the opposite healthy lung. Now, what are the risk factors for developing this 2 to 4% post-pneumonectomy patient that develop a bronchopleural fistula? If there is an inflammation, for example, from, infection like tuberculosis, necrotizing infection, something. If there is tumor in the bronchial margin, it increases the risk. If there is poor blood supply or damage to the blood vessel in this area, it increases the risk for the fistula. If there is irradiation before the operation, it increases the risk for fistula. If there is contamination of the pleural space, it increases the risk. So inflammation, infection, radiation, tumors, those are the same things that increase the risk for developing bronchopleural fistula. Now, when we are looking on imaging, what we see on plain films is a pneumothorax that is progressive and persistent. And we also see that suddenly the mediastinum is shifted, but now instead of shifting to the area with the void, there will be shift of the mediastinum to the healthy area, to the healthy side, what we don't really expect when there is pneumonectomy without complication. So if this happens, it may tell us that there is a complication. Now, on nuclear medicine, you may see xenon leak, and in sonography without contrast. You may see the size of the pleural cavity and the bronchial communication. Also, you may see it with thin slices CT. Okay, so this was about, let's say, postoperative chest with pneumonectomy, lobectomy, subsegmental resection and segmental resection, and post-pneumonectomy syndrome and bronchopleural fistula that can develop, for example, after pneumonectomy, around 2 to 4%. Thank you very much. If there are any mistakes or correction about this post-operative chest, tell me. That's it. Thank you very much. That's it.